much for the kind introduction, and thank you very much for the invitation and the opportunity. It's a privilege and pleasure to come and to participate in the first Congress in primary immune deficiency in the Arab world. So, Salam alaikum, and I will continue in English as we haven't been able to master the language to participate in the assessment of who will have the best in Arabic presentation. So what I will focus in the next 15-20 minutes is about a new therapeutic option, and my colleagues here were very kind in order to set up the stage for me to talk today about this new therapeutic option. Because what we have seen already from a patient perspective and what we have seen already from a healthcare professional perspective is that, yes, the immunoglobulin therapies are working very nicely, either subcutaneously or intravenously. They're achieving the effect, they're achieving the results that they were designed to do, basically to prevent patients from infections. However, not all therapies and not all patients are fitting each other together, and we may need to have something else in addition to what we have. So here is my disclosure, because I'm working for the industry, and some of the things that I will say here may be not approved in your countries, so please carefully read the instructions, and according to the regulatory documents in your countries, I may be speaking off-label here, but it's okay. So these were the features of the ideal product that Martin has presented from a patient perspective, and definitely less needles, less infusion time, no going to the hospital. These are some of the things that patients are requiring. Less systemic adverse events. And is it possible to achieve this as well? This was also what was presented by my colleague Nicholas. The current available therapeutic options. If one is doing something good, at the same time we have disadvantages. Is there a way for us to put these together and come out with a product that can be given once a month, but subcutaneously, can be given with one needle, but subcutaneously, can be given without the systemic adverse events, but subcutaneously? And so this is what was inspiring Baxter, and now Baxalta, a new company, to develop a new therapeutic option. In order to present this option to you, I'll give you a very brief overview of what we are dealing with when we are using subcutaneous therapy. And here is a very simple presentation of what is happening in the subcutaneous tissue. Basically, what you see here is a magnification of the subcutaneous tissue. You see the structural elements of the subcutaneous tissue, which are the collagen and the elastin fibers, which are proteins. And you also see that among these fibers there are many cells, there are immune cells, there are mast cells, but also there is a substance which we know as hyaluronic acid or hyaluronan. And this substance is a filler substance. The subcutaneous tissue is not an empty space, it is filled with this substance. And what happens when we inject a subcutaneous immunoglobulin or whatever subcutaneous therapy is that this hyaluronic acid limits the distribution of this substance, and in this case the immunoglobulins. It's not only limiting it and by this, but also creating a high pressure system, and this high pressure system depresses the vessels. In this case, which vessels are important for us are the lymphatic vessels, because they are very easily pressed. They don't have walls, it is just one cell, and these are the vessels that are associated with the absorption of the immunoglobulin molecules, since these are big molecules. And when these molecules when these vessels are depressed, the molecules cannot enter the plasma, they cannot enter the bloodstream, they cannot reach the organs, and they cannot do their job. In being administered subcutaneously also makes these immunoglobulin molecules vulnerable to the enzymes that are existing in the subcutaneous space, peptidases that are destroying them, and they attach themselves to non-specific targets that are existing as proteins and glycoproteins in the space as well, which leads to certain losses, and that's why the bioavailability of the subcutaneous therapy is approximately 60-70% of the intravenous therapy, which means that not all the molecules that are injected subcutaneously will reach the plasma and will be used. So I've been talking now about this phenylhyaluronan. What is a hyaluronan? Hyaluronan, very simply, is a polysaccharide, and we know it also as hyaluronic acid. Hyaluronan is has a rapid turnover, naturally degraded by hyaluronidases, enzymes that are splitting the hyaluronan molecule into smaller fragments, and it is very quickly resynthesized in the membrane of the cells, not in the Golgi as most of the glycoproteins are synthesized, but in the membrane of the cells. And about 1/3 of the hyaluronan in the human body is converted every day and resynthesized once again. And just, as a matter of fact, how much hyaluronan a male of 75 kilos will have is about 15 grams. It's a very small quantity. However, each molecule of hyaluronan has thousands of molecules of water attached to it, and this gives the turgor of the skin. This makes us look beautiful when we have hyaluronic acid injected by our cosmeticians. So that's why the people are using this as fillers for the wrinkles. Hyaluronidases have been used in the medical practice for a very long period of time, since the 50s. However, they were derived from animals, from bovine or ovine testes. And the issue with this, as you can see in the picture here, the dark colors, this means in this Western blot, it means that a lot of proteins are existing there, which is a reason for allergic reactions and less tolerability. What you can see on the left-hand side, which I have identified with an arrow, is the purified human recombinant hyaluronidase, which is a very thin line, which means it's a very pure protein. There is not so much risk of allergic reactions. And this has been used in the clinical practice. This enzyme hyaluronidase has been used in the clinical practice for different purposes, mainly for increasing the absorption and the distribution of other injected drugs. It's like a helper of the active substances to get to reach much better and much faster the plasma and the bloodstream of the patients. It has been used with infusion therapies like ringer lactate, antibiotics, morphine, and many other products as well in surgery. And so what happens is when we inject hyaluronidase, what's happening to the hyaluronic acid is that basically this hyaluronidase digs small channels, microscopic channels into the hyaluronic acid or the hyaluronan, which allows then the immunoglobulins to get dispersed in a larger area and to get to the bloodstream much faster at a higher level. Here is a very good example of how this works in practice. This is part of our experimentation with the mice in our preclinical model. You see the dye here, fluorescent dye, and on the left-hand side you'll see the dye alone, and on the left-hand side you'll see the dye together with the hyaluronidase, the recombinant PH20, as it is also known. And this is at the beginning. So what happens 6 minutes after the dye is injected alone? This is, you see the distribution, basically not too much, and you can appreciate that there is a significant difference in the distribution of the product measured by the area under the dye. What's happening with the skin after the injection has happened? The skin reconstitutes very quickly. Basically, what you can see here in the graph is that in the first half hour, the first 1 hour, it is still possible to inject huge quantities. However, after 1 hour, after 6 hours, after 12 hours, after 24 hours, this is no longer possible, which means that the hyaluronic acid is reconstituted, it's replaced again, and the skin integrity is not deteriorating. So let me go now much more into the specifics of the facilitated subcutaneous immunoglobulin administration, which is the new type of administration. And why it is called facilitated is because we're using a hyaluronidase, the recombinant pH20, in order to facilitate, to make it easier for the immunoglobulin to reach the bloodstream, but also for the immunoglobulin quantity that is injected under the skin to be increased multiple times. And I'm talking about 10 to 20 times higher than what is possible to do without the hyaluronidase as a immunoglobulin. The product that is used in this case is called HyQvia. I will show you a picture of this a little bit later. And it's approved in the European Union since 2013 and in the United States by FDA since 2014. There are approximately about 3,500 patients already treated with it. So this is the product, and you see it's a combination product. The small vial is the hyaluronidase, the enzyme that facilitates the absorption and the distribution of the immunoglobulins in the big vial, and this is a 10% solution. Here it is how it is administered, extremely simple. There is one needle that is placed in the subcutaneous space, and through this needle first is injected the hyaluronidase, the enzyme that facilitates the distribution and the absorption of the immunoglobulin, and then the immunoglobulin itself. It can be used with a pump, which is peristaltic, or syringe driver. It doesn't really matter, but it's a relatively simple thing to do. What is the results of the clinical study? Obviously, we'll be interested in the protective effect of this immunoglobulin. Definitely meets the requirements of FDA and EMEA. The point estimate of the acute serious bacterial infection was 0.025, much lower than the target of 1 that was set up by FDA and the EMEA. So very effectively protecting. And we have done the study that we've done continued for 3.5 years. And so we have seen also that the overall infection rate has been kept at a very low level of 3, at around 3, and it continued for the 3.5 years of the study. So there is no disappearing of the effectiveness of this preparation. Here is a very brief overview of the pharmacokinetic, and you can see the pharmacokinetic of HyQvia, or how the facilitated subcutaneous administration is depicted in blue, and it follows very closely the one of the intravenous preparation, which is in gray on your screen. However, there is no peak, and the lack of peak also explains the lack of systemic effects in comparison with intravenous. So we have much less systemic effects, about 3 times less systemic effects with this preparation. Here is what is the tolerability of the product, and this is the interesting portion what we have discovered. First of all, the average volume that was infused in the patient was about 300 milliliters in one site. There were patients ranging from 100 milliliters because we had small children, and there are patients getting up to 650 milliliters. The median speed was 300 milliliters per hour, which was even faster than the intravenous therapy, without causing more side effects once again. And the duration was approximately 2 hours for this preparation. What about the serious adverse events and associated systemic events? There were no serious adverse events, and the systemic events were, as I mentioned, about 3 times lower with HyQvia than with the intravenous therapy. There were local adverse events, as we can expect, but they were not higher percentage as the subcutaneous conventional therapy, although that we have used 10 to 15 times higher than conventional volume, and the speed was about 10 times higher, 300 milliliters per hour. So there were most of the adverse events, 98% were mild or moderate. Since the hyaluronidase is a protein, we have tested, is there antibody formation? And yes, there were about 18% of patients developed antibodies. However, these antibodies were non-neutralizing, and there was no any association with systemic or local adverse events, and we have followed these patients for the 3.5 years of the study. The antibodies are disappearing spontaneously while the patients are still on the treatment, and so there are no any concerns with this antibody at this point of time. Here is an example of what a mild local reaction may look like, the redness that is quite typical with any subcutaneous administration of any product. And also what you can appreciate is the small bulge or the small tumescence that is shown on the lower picture at the lower right hand. This is about 500 milliliter of infusion, and basically you can hardly see it. So this is another example, and this is probably my last or before last slide, of a patient who is treated, a real patient treated in Germany. And you see here 500 milliliter of infusion, and the last picture shows the effect after 24 hours. Basically, nothing's happening. So exploratory endpoint was preference of patients. More than 80% of patients preferred HyQvia to the other methods that they have used before, subcutaneous or intravenous. And as in conclusion, my last slide here, what we can say is that HyQvia, or the facilitated subcutaneous administration, offers a new option for patients in addition to the intravenous and the subcutaneous. Maybe not for every patient, but however, for quite a few of these patients, this will be a much better option to reduce the systemic adverse events, to avoid the intravenous or the vein availability, to avoid going to the hospital, being able to administer this at home, and to also be allow the physicians to inject higher levels, higher quantity of immunoglobulins, and to maintain higher trough levels in order to prevent infection. So thank you very much, shukran, and have a wonderful, wonderful symposium.